In May 2009, top medical administrators, physicians, nurses, community activists, and academics met at Princeton University to promote a dialogue about key issues, solutions, and policy recommendations regarding healthcare provision to underserved populations, including immigrants. What is Ailing U.S. Healthcare and Immigration, Access and Barriers was the title of the conference, a culmination of a 2-year-long research project sponsored by the Robert Wood Johnson Foundation and spearheaded by sociologist Alejandro Portes.
I think that the selection of this image that is all over the campus and has presided the conference is quite appropriate. I think that one of the things that we get from yesterday is that a lot is ailing us. A great deal. Indeed, I think that we are dealing in terms of the two issues, the two systems that are brought together here, the healthcare system and the immigration system, with two broken systems. Most of the rhetoric up to now is predicated on the idea of access to health for all Americans. That is, presumably access to health for all citizens and perhaps extended to established legal residents. Nothing had been said about new legal residents or about the undocumented. And that would leave, in a sense, the 12 to 14 million population, which is the one that shows at your doorsteps, or the ones that you often have to go get into one mobile van or another, high and dry. There is where immigration reform begins, because that is one possible way of handling the plight of the 12 million undocumented is to make them documented. That is, if the immigration reform that we have proposed here at Princeton and have argued in front of Congress has as its first priority regularizing in some form the undocumented population, the problem would get solved.
In other words, providing adequate services to vulnerable populations requires more than healthcare reform. It also demands an overhaul of immigration policy and a new thinking about who deserves medical care.
A lot of these individuals are individuals that don't have access to health care. Access, if we define it, isn't necessarily just being here illegally, and a lot of people misinterpret that and misunderstand that. If you don't have access to health care, sometimes it's a matter of timing, that you need to get that mammogram, but you can't access it because you're uninsured, and the next appointment is 6 months away, and you can't wait because you have a lump on your breast. So inaccessibility to health care isn't necessarily the paperwork or the illegal piece, and a lot of people misinterpret that. They think that just because they're going to this particular clinic that focuses on helping you access healthcare, that you are undocumented and here illegally. So the inaccessibility piece, and it's in our mission that we help anyone who cannot access healthcare elsewhere.
The goal is access to medical care for marginal or impoverished individuals and families, including immigrants, whether legal or not.
This is not simply a question of charity. It is not even a question of human decency, which would be enough. It is a question that the misfortunes of these people who come, harvest the crops and do the constructions and so on, are necessary and vital for the maintenance of labor-intensive industries in the United States, which have run out of labor as the domestic population have become more educated and have become more scarce.
Fear of deportation and the need to work can create delays that threaten lives and expand the cost of medical care.
One of the main barriers that we see is that there are quite a few, a high number of undocumenteds located in Miami, and they're very worried about if they come for services, will they be identified and taken off and removed. So a lot of our clients, when they do come to us, they're already quite sick, and so it makes the whole process much more expensive.
What then is the solution?
And my vision is that this underserved populations are able to access health care in a seamless, unified manner, a one-stop kind of process, centralized eligibility so that the patient doesn't have to go over and over and over again with their crises, their issues, their concerns, and then the documentation and the paperwork that they're required. So we're looking at centralizing that process and standardizing it.
Eliminating redundancies and facilitating communication among healthcare providers through the use of advanced technologies is part of the answer. Connecting primary and specialized care is also a vital component.
The other issue is getting our clients into specialty care. As a federally qualified health center, our expertise is primary care. But to get them to specialty care sometimes takes 4 to 5 months, and by that time it's difficult to locate them. Maybe they don't show up, and so we're not sure if they really do get the services that they need.
Federally qualified clinics are key in the mission to extend services.
There are several scenarios that come to mind. One in particular would be a best example. There is a church out on Key Biscayne, Florida. Key Biscayne is a very wealthy side of town, and the homes, in the homes are many maids and cooks and landscaping gardeners, and what happens is they have no access to health care because they're not allowed to leave their position except on Sundays to go to church. So instead of waiting for those women to come to us, and we're closed on Sundays, most clinics are closed on Sundays, what we did was we got a mobile van to go out to the church. So on Sundays, the ladies come in and they receive communion and get a pap smear.
In other words, a society unable or unwilling to protect its weakest members puts itself at risk. The extension of services to the poor, the immigrant, the undocumented is more than a moral imperative. It is also a practical matter in the attempt to keep healthcare affordable and accessible to all who need it.
That the federal government should expand the coverage of the federally qualified health centers to include at least some basic specialty care, such as cardiology, orthopedic, so that we can bring the clients to our clinic and let them be served versus them going someplace and us not knowing where they are.
We have to think about the burden to the system, because a woman who comes in and is able to get preventative health care, and we're able to educate them on family planning and able to educate them on their health and whatnot, makes a tremendous difference, as opposed to someone that comes into the emergency room in crisis. The cost and the burden to our system is outrageous.